Metal-free PCI has two horizons. One, we only do a balloon dilatation and do not put any metal stent. So now the second, that there are newer innovative scaffolds available which are not metal stents.
Metallic stent is also a disease because it will remain with the patient for lifelong and he or she has to be on antiplatelet. So there is always a need to have a metal-less PCI.
So if a patient has a high bleeding risk and he cannot take antiplatelets for a long period of time, again, bio-resorbable stents become a good choice.
First generation and second generation, we have used more than 2000 scaffolds and we haven't seen really any complication.
It has some good strength. It opens up a blockage and then in 1 to 2 years time, it biodegrades itself. For last decades, 2-3 decades, we have been doing PCIs, and all PCIs are practically involving to deploy a stent inside the coronary arteries to open up a blockage, and all these stents have been metal stents. So metal-free PCI has two horizons. One, we only do a balloon dilatation and do not put any metal stent. So, but then that is not very successful because we know if we only do a balloon dilatation, that there is a recoil chances are very high and restenosis will happen in 60% of cases. So now the second horizon of metal-free PCI is that there are newer innovative scaffolds available which are not metal stents. So they are made up of a material, it has some good strength, it opens up a blockage, and then in 1 to 2 years time it disappears. So it biodegrades itself inside the body without any harmful effects. So this is a very good concept.
So if you see the PCI, which is a life-saving procedure, but when we put stents, metallic stents, especially in Indian context, if you see, there are a lot of patients who are having coronary artery disease in very young age. In fact, before coming here last evening, I had to do 2 PCIs in patients who were just 31 years of age and 35 years of age. Now imagine they have to take the whole life, the antiplatelet. But I chose to put metal-less stent, which is, absorbable scaffold, so that once it gets absorbed in 3 years, the patient can come off, because the other where the arteries were absolutely clean. So I would say that a stent is also, metallic stent is also a disease because it will remain with the patient for lifelong and he or she has to be on antiplatelet. So there is always a need to have a metal-less PCI. We are working in 2 directions. One is the absorbable scaffold. The first generation had failed, but this second generation is really good. It's much more advanced. And the other direction is the drug-eluting balloon. But as you would know that drug-eluting balloon will not be foolproof because there is by definition, the treatment of ballooning will involve some dissection and also you need to put some stent. So metal-less PCI is something which is necessary.
So we all understand that angioplasty has become a standard of therapy of many of our patients with multiple vessel disease, and we do an angioplasty and then put in a scaffolding which is known as a stent to make sure that the arteries do not restenose or they do not collapse again. Now we are looking at patients who are presenting much earlier, and we know that once you put in a stent, there is always a chance of restenosis or a reblockage in the stent. And the earlier problems were that if you put in a stent in this particular location where you've had a reblockage and the patient needs to go for a surgical procedure which is known as a bypass surgery, the surgeons would have a hard time to put in a graft or a new vessels into an area where the stent has already been placed. Though it can be done technically, it did pose some challenge to the surgeons, and therefore what we are moving towards is something that is known as a metal-less stent or a bio-resorbable stent, where we use a stent into the artery once the patient needs it, and then over a period of time, usually over a period of 6 months to a year, the stent dissolves off and it leaves behind only a normal artery which is able to contract, which is able to work like a normal artery, and it also gives the patients a chance in case there is a problem in the future for a surgical approach of a bypass surgery, because since there is no stent in that area, the surgeon is able to put in his surgical grafts with a much greater degree of ease and with a better long-term result. So our practice has been that when we have a younger patient, a patient who has multivessel disease, and especially in the target areas where the bypass surgeries are usually done. So in those areas of the coronary tree or of the coronary artery where the bypass grafts are usually inserted, for example in the mid part of the left anterior descending artery or in the posterior descending arteries or in the obtuse marginals where the grafts can usually be placed, we would tend to use a bio-resorbable stent in those areas, knowing that we don't limit ourselves to those areas itself, but also knowing that there are certain patient subsets where using a long-term dual antiplatelet or giving blood thinning medicines for a long period of time becomes difficult, especially in patients when they have these complex lesions where we now talk about giving these antiplatelets for a long period of time, say 3 to 4 years also. So if a patient has a high bleeding risk and he cannot take antiplatelets for a long period of time, again bio-resorbable stents become a good choice because we are able to then probably get off the potent blood thinning medicines much earlier, because these patients do not have a metal scaffolding there, which would make sure that they need to take these medicines for a longer period of time.
The most suitable patients or patient subsets where we can think of opening the blockages with the biodegradable scaffolds are young patients with soft compliant arteries where the blockage is 90% and they are presenting with unstable angina or acute MI. So it is 1 or 2 blockages, not a very multiple blockages, no calcification attached to those blockages. It should be softer blockage. So these are the patients, even in elderly patients. If it's a spot lesion, single lesion or 2 lesions but focal lesion, not very lengthy, not very calcified, and artery size should be good, not very small arteries. I think these are the lesions which we should attempt with biodegradable scaffolds. I have done many and with a very good results. So primary PCI is a PCI which we conduct in acute MI patients to open the occluded arteries which is causing a heart attack. I have used these biodegradable scaffolds to open such clogged arteries for acute MI. But then again it has to be a bit selected. We have to be a bit selective where the thrombus or clot burden is lesser. If we can evacuate and then the artery becomes good and it's again a softer artery, we can always think of giving a biodegradable scaffold. Now most of the biodegradable scaffold PCIs which I am doing, usually I am also doing a adjunct coronary imaging along with, and that gives the best results. So if we have a coronary imaging, if we have a acute MI patients who's relatively younger, 30 to 50 years of age, and we do a angiography and find out the clot burden is not very massive, we can always think of opening these blockages with biodegradable scaffolds.
The metal-less PCI, the scaffold would need to, they are slightly bulkier device and they need to expand fully to give you the best outcome. So the preparation of the bed is very, very important. In that case, you can use techniques of balloon preparation, you can use cutting balloon also, you can use coring balloon also, and 1:1 dilatation should be there at least, and then only take your metal-less scaffold, because its full expansion and apposition to the wall is important. Unlike the metallic stent, their post stent, if it is not expanded, you can blow at a very high pressure and achieve expansion. But with this, if you have not prepared the bed, it will be very difficult to expect from a non-metallic scaffold to break up the lesion, especially the unexpanded lesion, and go to the normal diameter. So preparation is the key to success, and in our experience, I would say that with first generation and second generation, we have used more than 2000 scaffolds and we haven't seen really any complication, because we kept always preparation, 3 P's there, that you have to prepare, do a preparation, post dilatation. So all these things has to be really kept in mind, and it's the usual standard practice of taking care of the PCI.
See, the other area that we use a bio-resorbable stents is where we have major side branches. The problem is that when you use a medicated stent or the normal conventional drug-eluting stents, if you have a large side branch in terms of an area that is supplying a major area, the concern was always a pinching of the side branch. So when we stent into the major branches, a major side branch can get pinched, and then we had to do a complex procedure of putting another stent into that artery. By using a bio-resorbable stent in those areas, the incidence of pinching becomes much lesser, because even if you have a pinching that happens over a period of time, since the stent is going to get resolved, the side branch access usually opens up, and it makes it easier for the patient to have a future procedure without the risk of having to continue, as I said, a dual antiplated for a longer period of time, or making a procedure more complex with a bifurcation or a trifurcation stenting. Yeah, so as we are moving away from stenting, we are realizing that having a foreign body inside the coronary artery is something that is not very comfortable for a long period of time, and therefore we would like to leave lesser and lesser things into the coronary artery. We are now moving towards an era, especially because of the fact that India is a diabetic capital. We do see a lot of patients who have diffuse distal vessel disease, where even if you put on a stent in the proximal part of the artery, the distal part of the artery shows multiple areas of atherosclerotic plaques. So if you have a disease that's there mostly in the distal part of the artery into small vessels where we may not be able to put in a stent, I think those are the areas where drug-eluting balloons are being commonly used in our clinical practice. The other areas is in-stent restenosis. So when you put in a blood drug-eluting stent and the stent has re-stenosed or it has a reblockage again, we would probably, rather than putting another stent, find out if the mechanism of restenosis is under deployment or new intimal atherosclerosis, and then treat the new intimal atherosclerosis by means of a cutting balloon or some form of debulking, and then use a drug-eluting balloon to deliver drug to that area. By this method, we prevent the insertion of another stent. So rather than having two stents into the coronary artery, you can probably have a good lesion preparation and then end up by using a drug-eluting balloon there. And this approach has been shown to be very beneficial in many of our patients with in-stent restenosis. We need to individualize our therapy for patients, and I think, as I said, if it's a large artery, it's a proximal left anterior descending artery, I think my choice would still be a drug-eluting stent rather than a drug-coated balloon for now. But if it's a side branch, as we talked about, it's a left main disease with an ostial circumflex disease where you do not want to leave too much of a metal jacket there, I think the choice would be probably more to do with a drug-coated balloon rather than using a stent there. So I think, as we said, it is an individualization that needs to be done, and both of them work synergistically. They are not sort of contrary to each other, and as we say commonly, it is to treat the patient, not the lesion alone.
The lesion preparation for biodegradable scaffolds should be more meticulous, more scrupulous, more efficient, I would say, where initially we should take a bigger balloons to open to pre-dilate the blockages, I would say. And if we find there is some hardening of a blockage, I mean blockage seems to be hard, we should take the help of cutting balloons or scoring balloons to debulk that blockage. And once we have done that, yes, one thing more, the balloon which we take to pre-dilate should be almost in the ratio of artery size ratio of 1:1. If it's a 3 mm artery, we should take 3 mm balloon and go on good atmospheric pressures of 10 to 15 atmospheres, and then take the scaffold. That prepares the bed in a better way, and scaffold expansion and scaffold opening is much better after we have prepared the bed prior to the scaffold, and that gives the best results.
ISR is again, as the number of PCIs are going very high, then we are bound to see more and more ISRs in absolute numbers, even if the risk of restenosis is going down, but the absolute number of ISR will go up. So we have got two main options in that. I would say rather three. One is that we do, PCI with conventional, another layer of metallic stent, which is not the great option, I would say, especially if the artery size is not more than 3 mm. Then we have the option of going with the cutting balloon and then putting a drug-eluting balloon there so that you don't put another layer. But we have had a good experience with, metal-less scaffold, that is the absorbable scaffold, especially in arteries which are 3 millimeter or 3.5 millimeter or 4 millimeter. In there, I would say that this technology will score over both the other technologies because it has power of healing it, giving the good support for initial few months, and then it disappears and gives a de novo artery. So I would say that this is having a great future in that. But with the word of caution is that do not use it in less than 2.75 millimeter artery.